This is our first talk for the season. We have the pleasure, he's a very busy guy, so I'm pleased that we managed to have him over. Exactly. This is Dr. Ross Johnson from University of Pennsylvania School of Nursing. He will tell us about HIV today. Not only strictly in terms of virology, the structure and how the virus infects, but also, I understand, socially and healthcare-wise and other things. I had the pleasure and the honor to know Ross since late 90s, 2000. We actually at that time we worked together at UPenn. I was a postdoctoral fellow. He was a PhD student. So he has obtained his PhD on immunology at UPenn. Later he did his Masters of Public Health at Johns Hopkins University, School of Public Health. He served as faculty at Virginia State University, Chicago State University, and recently, 2015, I understand, he joined the nursing school at University of Pennsylvania, and he's practice associate professor. His activities include intense teaching, education, research, and I bet you're also involved in administration.
Yes.
Of course. So, without further ado, I present you Dr. Roy Johnson. And I will pass on the attendance list so you can sign in.
Okay, so first of all, thank you all for coming. I'm gonna do a couple things I know that are radical. I might ask you as I'm lecturing. I'm going to ask you questions as I talk, not necessarily quiz questions, but just to engage you. So the first thing I want to know is, off the top of my head, how many people are pre-nursing or nursing? Okay, how many people are pre-med? How many people are like a lot applied health, dentistry? How many people are just interested in HIV? Okay. Anything I missed that you want to shout out to me now?
Dietitian.
Dietitian, okay. Anything else? Okay, so what I tried to do for this talk, and it's more of a conversation, is to be able to engage with you a combination of both public health as well as immunology. So I'm a recovering immunologist, as Dr. Algier said. One of the things when we first started doing the work, so how many people know how long it's been since HIV came about? Like when, yeah?
81.
81. So in 81, we started to discover that HIV was, we started to discover that there was actually something that was causing a lot of young men in this country to be infected with and have a response that normally young men didn't have. They had, anybody seen the movie Philadelphia with Tom Hanks? Okay, so when Tom Hanks is in the courtroom, he takes his shirt off, and you see all the marks of lesions on his body. Those are called Kaposi sarcomas. They're skin cancer, and normally don't see them in young men. It's not showing up. So anyway, so one of the things that that we started to identify was that young men were coming down with this kind of disease, but we didn't necessarily know what it was caused. So originally, no one even knew that HIV, what HIV was caused for. Does anybody know what it was first called, what the first name was? Yes?
Was it GRID?
Yeah, it was GRID. Which, you know what it stood for?
Tell me again.
Gay-related immunodeficiency, right? And so there was a period of time when individuals who were women were not even expected to be able to get HIV. Right? So they had, but the weird thing about that was that the 5th patient in the first paper that was published in the United States had HIV. So there was data already, but because of kind of policies and politics, it became linked to just gay men, okay? So, anybody know what the 4-H club was, which was the first group that people used to talk about related to HIV? Okay, so, okay, I can pull it. So, the 4-H club was homosexuals, hemophiliacs, Haitians, okay? And basically, I can't remember the fourth one right now, but here's the thing. People from Haiti had a high proportion of HIV because it had come to Haiti before it came to the United States. And in most parts of the country, of the world, HIV is actually I'll just reset. Is a heterosexual disease. So that's why the title of my talk actually is H is for human, because basically, oh, that's not it. It's the red one down here. It's the red one. Is that C? So basically, what that means is that if you're human, you have the ability to get HIV. If you get exposed to somebody who is infected. Okay, so one of the things that we're going to talk about today is we're going to talk about, first of all, how it is a pandemic, meaning that it is all over the world. And that of that pandemic, how we're going to talk a little bit about how it plays out locally in the United States, and then how as you, as people who are interested in it, as well as people who are potentially, possibly open to being exposed to it, how it'll play out. Excuse me one second. So let me ask you this: as I'm trying to get this on a USB, what do you think? Have you heard? What have you heard? There's some commercials right now. What have you heard in commercials right now that relate to HIV and the reduction of potentially getting exposure? Yes.
There's a drug out. I think there's two. There's one called PrEP, and then there's another one called Prevalence.
Okay, so Prevalence and PrEP are basically the same thing. All right. Let's see. Does anybody know what they do? Yes.
They prevent HIV if you're like at risk of getting it from sex.
Okay, but if you are HIV negative, okay, so what it is that if you're HIV negative, it prevents you from getting disease. It has a higher chance. Okay, so very good. It has a higher chance if you're HIV negative. All right, and so what that means is that if you are potentially going to do risk behaviors that might give you an opportunity to get exposure to the virus, it is a way, if you take the drug and take it regularly, that it will highly prevent you from getting it. Okay, so nothing is 100% though. Okay, but it is. Thank you very much. Okay. All right, thank you. All right, so one of the things that you hear now is about having the opportunity to be able to prevent you from getting exposure. But as you can tell by the audience response, not many people know about PrEP, right? Not many people know about Truvada, even though they do have a very nice set of commercials going on right now. Where they have various different types of people who basically talk about in a very nice way why you're using Truvada or PrEP in an effort not to get HIV, all right? But otherwise, do we hear much about HIV anymore? I mean, it's almost like in this country, we almost act, unless you're really in the process or you're in groups that are high risk or considered high risk, right? It's almost like HIV evaporated, right? So this time of year, what do people normally ask you that's health related? Just general population questions. Yeah.
Like breast cancer.
Breast cancer, right? What else? Flu vaccine, right? Did you get your flu shot? Right? Okay. Nobody walks through and says, hey, you've been HIV tested? which is if you're doing anything that potentially could expose you to HIV, it's a really critical question. Because what we find out is that for a lot of folks, and this on the public health side, is that for a lot of folks, let's say it's a gentleman, he's in his 30s or 40s, he had one HIV test 10 years ago, right? He's still engaged in potential behaviors, i.e. he's having sex, right? Or he's taking drugs or whatever that may have exposure for HIV, and you ask them, that individual, are you HIV negative? And they'll say, yeah. And you say, well, how do you know? And they'll go, I took a test. And then you ask the follow-up question, when did you take the test? Oh, 10 years ago. And then you go, well, I'm happy you got the test results 10 years ago. Have you done anything that might expose you since then? And then they kind of pause, okay? And the realization is that we have not standardized. Just like we talked about, everybody says, oh, it's flu time, we know it's the flu. We need to standardize, and that's one of the things that's really a passion of mine, trying to sustain people who may be potentially exposed to HIV to get tested, because we know that's an effective way. So when's the origins? Well, we know that it is a virus that crossed over. What does that mean? That means that SIV, which is simian immunodeficiency virus, it's been found in monkeys and primates in Africa. And the structure of the virus for simian immunodeficiency is very, very similar to HIV. So the question that some people will say that's crazy is, well, were people in Africa having sex with monkeys? No. Okay, that is a foolish statement. Okay, all right. The reason that it crossed over is because just like we might see stray cats, or we might be exposed to animals in deer or whatever, in parts of Africa, primates are everywhere, right? And the other thing that happens is that people, especially people that may not have the same kind of means that many of us have in the United States, eat bushmeat. Bushmeat is often people go into forests, get primates, small primates, skin them, and then eat them. Now, in the process of skinning them, if you've ever seen anybody, you've done it yourself, there's knives and there's pieces, and you can potentially get cuts, and you can get cuts from other stuff. So we think that it transitioned through that way, and it got humanized, meaning it adapted to being in a human body, and then it was able to be spread through humans, right? But nobody actually was there to do a case study on it, so we don't fully know, but we're just looking at it. We believe it's been around for a lot longer than the 1980s, all right? So I just want to let you know that until like the 80s, we didn't even know, we knew that it was going on, right? But the people who die, who have HIV that goes into AIDS, they don't die from that. What do they die from? Everything else, right? So they die from tuberculosis, they die from mycoplasma infections, which are respiratory infections. They die from lots of other things, but not from HIV. Because what this virus that's so effective at decimating our immune response does is that it basically makes our immune response non-functional. And because of the non-functionality of it, we're able to be exposed to lots of different things. All right. So what happened then is that as we started to look through, we found that in the 80s, it was everywhere. It was all over the United States, all over Europe, all over South America. But the biggest place was, anybody know where the biggest place that took the biggest hit? Africa, sub-Saharan Africa. And so this area, the darker the color, the more HIV infections there are, right? And so when we talk about adult prevalence, that means how many adults there are that already have HIV, all right? And so in parts of Africa, there were whole generations of parents that got HIV, this is earlier on, got HIV, got AIDS, died, okay? And so you had this gap where you had grandparents taking care of their grandkids, because whole generations of folks were getting HIV, going into AIDS, and dying. Now, because we don't talk about it much, a lot of people in the United States, unless you're really interested in this stuff, thinks that the epidemic, the pandemic, has gone away. The thing that we've been able to do, and part of this is related to things that the federal government has done, is we've been able to actually reduce the amount of people who have active virus. What does that mean? That means that when you get the disease, you have a real spike in the virus. It means you're highly infective. Then the virus gets quiescent. It gets into your body. It does things that we can't see, but we don't have any symptoms. And then as it's killing off our immune cells, we start to then have other effects. Our immune system doesn't respond, so we start getting other colds and so forth, right? And that period can take somewhere between 8 to 10 years for a lot of folks, right? So in other places, we've had, as the United States and other parts of the world have had a massive amount of input in these countries in an effort to reduce. And so a lot of the trials for the drugs have actually been done in various countries in Africa. And we basically make sure that, you know, it works for their group, and then we roll it out, and then we study it, and then we report about it, and then we bring it up. We bring it here. All right. Now, the thing I want you to be aware of is that this information I'm showing you is from 2017. So this is not, although the number of deaths have dropped, it's still a problem in parts of the world. All right. And the reason I talk about how when we look at this, so this is the number of, since we got drugs, so we got antiretroviral drugs, and then we have things like PrEP. So we have drugs that can prevent you, once you are infected, from going into AIDS, so you're HIV positive, but you will not go into AIDS and die. And so we actually have a cohort of people in the United States and other parts of the world that have been on these antiretroviral drugs for a long time. And now, for many of the people that do their regimen, it is a chronic disease, meaning they have the disease until they die. And many of them die from other things other than HIV infection that goes to AIDS. That's great, right? Same thing's going on in parts of Africa. As you can see, it's a massive decrease. All right. The problem is we still are getting new infections. Okay? We're getting a lot of new infections. I mean, not as much as we did before, because we dropped the amount of people that have active virus, but if you have HIV, really, there's only been a few people that have been able to get rid of HIV since we've established it, and it's real radical things going on in order to make that happen. Yes?
So my mother's boyfriend's uncle passed away from HIV-related pneumonia about 30 years ago.
Okay.
So do you have anything to say about that?
Say it one more time.
My mother's boyfriend's uncle passed away from HIV-related pneumonia about 30 years ago.
Uh-huh. What's the question? You give me a statement.
So like how, like what caused HIV? It caused pneumonia.
Oh, okay. So what happens is that, and I'll get to this in class, this is part of the lecture. What happens is that it actually knocks out his immune system, and I'll talk about that in a second, so that the pneumonia was in the environment, he got exposure, and basically he couldn't fight it off because his body was decimated. Okay? And that's really what happens to people. Okay, so what they're saying is because it was AIDS, because AIDS had dropped his immune system, the pneumonia was able to take on and cause his demise. Yes?
From exposure to the virus, how long until you test positive?
About a month. So basically, standard procedure is you go in, if you went in tomorrow and got a test, right, and they said, this is the first test you got recently, you say yes, they would actually come back in about a month to 12 weeks. Because the test can't, like if you got HIV yesterday, we can't detect it in the test. Yes?
I think that what a lot of times what people aren't aware of is that when people think of HIV, they think about it being sexually transmitted, and how you were saying about the bushmeat, like when people don't have viable resources, that it's also transferable through breast milk.
Yes,
and when that's the only way to feed your child, it's kind of like, what do you do? Does your child go hungry, or do you give them the breast milk knowing that it could potentially infect them?
Right, and so that's one of the reasons why we want people to be screened, because if you're an expectant mother or want to be a mother, if you know you're going to be breastfeeding and have a child, we want to get you on antiretrovirals that have been proven to be able to be fine and not cause a problem. Yes?
Yes. My question is it possible for someone to die from another disease that's not AIDS-related, like to say, because sometimes where I come from in Africa, people don't find the actual disease that shows. So most of the time related to HIV. Is it possible?
Yeah, it's possible if you have HIV that you die from a lot of other stuff, but it's also possible if you have HIV and don't go to AIDS, that just because your immune system has been slowed down and not as effective, for you to also get some other kind of infection or disease. Okay? All right. So let me just move along a little bit. Okay, so one of the things I want to talk to you about is the fact that part of this deals with kind of place, right? And so humans, like for humans, place really matters. And so what this is called the Ecological Model, and it's from a researcher at Hopkins named, whose name I'll give you in a second. But basically what I want to show you is that for this, it's talking about in your particular area, how prevalent is HIV? And why is that critical? It's critical because if you're in an environment where there's no HIV, your chance of getting HIV is 0. Okay? If you're in an environment where there's HIV and you don't do anything that would expose you to HIV, your chance of getting HIV is 0. Okay? So one of the things you have to keep in mind is what's going on in your environment. And so let me just go back. So if you are in places in parts of Africa that have a very high prevalence, meaning individuals who have the disease, you have a greater chance of getting exposed to the disease if you're doing behaviors or you're having breastfed children, mothers who are HIV positive, so forth and so on. So the fact of the matter is that place is really important. All right. The other thing is, what's your public policy? Right? What's going on in your area that deals with how HIV is handled? Right? Is it stigma? So you do not talk to anybody about it, and even though you may think you got exposed, and therefore you keep moving forward? Is it such that you can go to a clinic that has treatment and you can be kept, anonymous, right? And I'm not saying that people will know you, but not necessarily that it's out in the world, is what I'm saying. And then also, what's your community do, right? How's your community looking at it? What's your social networks? And then what's individual levels, right? And so I bring this up to show you that humans are able to be mobile, right? And so even though we show you this context of countries, people can leave their countries. If they're HIV positive, guess what they bring with them? They bring HIV, right? If they're on a regimen, if they're on taking drugs, and they can stay on their drugs, they will not necessarily introduce HIV into the community that they move to, but they still are HIV positive. Okay, so just looking at different types of people, if we're looking at for people who inject drugs, right, and we have some big places in the Philadelphia area where people are doing drugs and injecting drugs, you also have an area where, once again, for this particular community, that place and that group of people they may deal with may have a high level of HIV, and so therefore they have a greater chance. If they also have group involvement with people outside that community, they can spread. So before Vice President Pence was vice president, he was over the state of Indiana, and Indiana had a really small town where somebody was HIV positive, they were doing IV drugs, it was a lot of people, and basically you went from having 0 cases of HIV to quite a few proportional to that town. Right? And so it became a mini epidemic. And the reason he was getting roasted in the news and in the public health area is because we know that there's lots of ways if people are using drugs. You can't necessarily stop them from using drugs unless they want to. But there's lots of public health methods like needle exchange where they can get clean needles, right, in order to minimize transfer of the disease. He was very, very, very against that for a lot of reasons until the numbers just kept popping up. Because IV drug use is actually what spread HIV in lots of places. Okay, all right. So it's also a key component. And then the last one I'll show you is basically when for this country, a large portion, and in other parts of the country, of places, large portion of the people who are newly infected were men who have sex with men. Men who have sex with men is a designation that was given because it's more about behavior than identity. So in the early times, people would say, "Are you gay?" And the guy would say, "No, I'm not gay," because he did not identify as being gay. When they realized it was about behavior and they said, "Do you have sex with men?" they would say, affirm that. And so therefore we started using men who have sex with men. Right? Now for some gay advocates, they were pissed because they were like, we spent a lot of time being able to call ourselves gay. Why do you want to go back to that? But it kind of stuck because there are still men who are who consider bisexual, or only occasionally have sex with men. They do not classify or identify themselves as gay. So looking at this, once again, is what is the stage? Where are you at? If you're in a certain place like DC, parts of Philadelphia, that may have a high gay population, some portion of that population may also have HIV, whether they're on the regimen or not. This plays a role. So how much are you getting infected? So we have to think about what are the factors that people might have to deal with. How educated is the population that we're looking at, right? So people and places really matter, all right? So the question I ask you is, if the community you live in or work in, right, what's the epidemic stage in your community? right? And that's not a question for you to answer, but it's something to think about, right? So if you're in an area where basically there's no prevalence of AIDS, there's almost nobody that has AIDS, or you don't do any behaviors of AIDS, your chances are pretty minimal. But if there is a group, let's say young adolescents, that are doing things that potentially could lead them to getting AIDS, that's something you may want to think about. How do you work on policies or places in your community that can be supportive if individuals end up getting HIV? All right? Everybody with me still? I just gave you a lot of stuff, I know. All right, so one of the things I want to talk to you about is when we talk about the immunology of it, right? So what's immunology? Immunology is basically how we recognize and respond to things. Okay, so right now, we're worried about the flu, right? How many people have gotten the flu vaccine for this year? Okay, two, three people, 4 people? Okay, 5 people, okay, good. So right now, we just at the start of the flu season. That vaccine was developed for a specific number of flu viruses. Okay, mind you, there's hundreds of flu viruses. So they picked a few, they got a vaccine. Those of us who got the vaccine, we have developed in about 2 weeks recognition for those particular flu viruses. And if those flu viruses are the flu that come to the United States, we will have some level of protection. Okay, the problem is that sometimes the flu that comes to the United States is very different. And so therefore, the vaccine may not be effective to what comes in. So we develop what's called adaptive immunity. Okay, the adaptive immunity is the part that allows our body to respond faster, right? What we found that in things like HIV is that our adaptive immunity for HIV is not really that effective at preventing disease. So even though we have adaptive immunity, it requires certain cells. So I'm going to skip a couple just because of my time. Okay, and so what happens is often we have cells in our immune response that will take in our pathogens or parasites or viruses and basically break them down. So this is like a macrophage, right? And then what they'll do is they're all throughout your body, so I'm going to just move forward to it. They move through your lymph system. And basically what they'll do is, I'm trying to get to one particular, they'll get the T cells. And then T cells, or CD4 cells, will actually recognize part of the antigen. All right? And that stimulates your immune response. All right, now, here's the caveat of HIV. HIV attacks this cell. And so this T helper cell, the one that triggers and is like the quarterback for your immune response, is now the cell that's infected. And so what happens is as this cell is infected with HIV, over time, the number of cells you have decreases. And because of that decreasing, basically, the response to those types of antigens and being able to be a quarterback or lead the charge in your immune response, it can't do it. Okay? Now, why is that a key? Because whenever we have any kind of cold, any kind of infection, T cells end up at the site. So if you get HIV at a certain site, let's say the vaginal or rectal area, right, T cells will end up down there, right? The virus is down there. T cells are down there. Then the T cells will take the virus, become infected, and move the virus to other parts of the body. Therefore, T cells not only get infected, but they're also carriers of the virus to other places in the body. Okay? And so this is part of our dilemma. So when we first had HIV, we thought that we could master a vaccine, and I was part of that team at Penn, where Dr. Algiers talked about. We were looking at HIV vaccines, and we developed something that had potential, but the thing about the virus is that it mutates. So it means it changes, and it changes a lot. And that mutation rate has been our bane of our existence. So we have not been able to develop a vaccine yet, which is amazing considering that it's 2019, okay? And if you think about most of our viral infections, we treat them with vaccines in order to prevent it. All right, so I'm gonna just keep moving forward. All right, so one of the things, if you're thinking about immune responses and antibodies, but what I wanna say is that what happens is you would see this first exposure, you would have a primary response, and then you have a secondary response. So if we had a vaccine, our primary response would be after we had the vaccine, and then when we get exposure, we have a secondary response, and the hope with the secondary response is that we don't get the disease. All right, so that's the whole principle behind it. But we have not been able to get a vaccine. So let me just move on. Okay, so let me just say this one. This here just shows you that for T helper cells, because they are very much involved, they help both the B cell, the antibody responses that we have, as well as the T cell, which is the cytotoxic T cells. Cytotoxic T cells are another branch of your immune response that's really specific to kill viruses. So by attacking the T helper cells, right, we can't make antibodies that are highly effective, and we also can't make T cells that are highly effective. So therefore, as our CD4 T cell count goes down, if we're now on the meds, we start to develop other infections. All right, everybody with me? Okay.
So the medication isn't to help with any HIV symptoms, it's to boost your immunity so you're not susceptible to anything else.
So the medication is to prevent the virus from really being active and destroying your cells. And that's why we want to get you on the medication as soon as possible. So one of the new things is test and then actually start prescribing meds, even if we don't necessarily know the end. Yes?
I'm bisexual, let's say.
Okay.
Let's say if I start having sex with other men.
Okay.
I'm gonna start taking PrEP to prevent myself from getting the disease.
You want to start talking to a provider, and you want to take PrEP. I think they said that you should take PrEP a minimum of 5 days a week. Okay? It doesn't have to be every day, but you want to take it 5 days a week. The other thing is you want to follow the other guidelines with taking PrEP, so it's also just safe sex protocols.
But I'm sure there's side effects with it, right?
There's some side effects, but it kind of depends on the individual. But it's not nearly as bad as it was when the first antiretrovirals came out.
When was that, by the way, I wanted to go to that. Was 1995 when AIDS became more curable, or AIDS, not curable, but less than deadly?
Yeah, so I mean, when Dr. Wu, Dr. Wu, David Wu came out, that was one of the first antiretrovirals. But the problem with that is that you had a lot of movement of fat in the body. So a lot of people that were slender started to develop these whole big, like I had because I'm fat, but fat deposits, right, because of the drug, right? So they had changes, and also some of the effects were just really bad, you know. But we've gotten to the point, if you stay on the regimen, we can give you one drug. I mean, one pill has 2 drugs in it, and it can be very effective against preventing you going into AIDS. So.
Sorry. I wanted to ask you another question. Were there any improvements made before 1995, or was it like really bad?
Well, no, because what happened is they were doing a lot of clinicals and different things, but the key thing about drugs is about being able to take them regularly, right? And so if you're getting a drug and it's making you sick, what's your chances of probably taking those drugs, right? So that's part of the problem. So getting it to the point where people can take it and be committed to take it, okay? So yeah, that was a major breakthrough. Thanks for bringing that up. So I'm gonna just move to this last part. Okay, so here's the thing. When we look at this 2014 data, but what I want to show you is that this is, once again, the darker, the more people that have HIV, living with HIV. This is 2014, but it's basically the same thing. You go down this corridor, you go around, you go to Texas, right? You kind of skip over little places, right? You go up the coast, right? There's certain places in here that you see very low prevalence. What we actually see is a lot of folks that have HIV have a tendency to move towards cities, right? And part of that is because of the fact that for medical situations, but also because of the population they may want to be around, okay? But we still have a whole group, especially of African Americans who are actually in the rural South who have HIV, and because of stigma, have not necessarily dealt with that. And so we're trying to think about how can we connect and move the stigma down so that people can actually get treated. All right, when you look at it through just 3 parameters, look at whites, as you see, it gets a lot lighter, proportionality, but once again, white people are human, black people are human, Hispanic people are human, so it's more about how prevalent it was in your community. That's why I showed you that first ecological model. And so what they found is that in certain communities, people have sex in their community. And that if the prevalence is higher in that community, the chance of you meeting somebody who has HIV greatly increases. Okay? And when you look at, once again, Hispanics, you see some hot spots, but once again, certain areas where you have large groups of Hispanic folks living, you see it. But it's definitely what we call a health disparity, meaning you see a lot more in certain groups of people. Some of them are gender minorities, some of them are sexual identity minorities, some of them are ethnic or race minorities, right? But there's nothing about those individuals that makes them more prone to HIV other than they were environments that had a higher possibility of getting exposure. Everybody with me? Okay. All right. And so just to give you some comparison. So this is just comparing states. So this is New Jersey, and this is Pennsylvania, right? And so if you look here, if you look in Jersey, there's about 475 people out of every 300 people in New Jersey are living with HIV. All right. The reason some of these dates are the data is from older years because people have to do statistics to get all this data. And then if you look at Pennsylvania, it's 309 for every 300,000. Right? Now, 100,000. So the thing you want to realize is that proportionally, there's more people living in New Jersey than in Pennsylvania. Proportionally. Okay. Now, the thing you have to keep in mind is when you look at total population, though, right, it may be a little bit different. So as we present numbers, realize that you may see one number higher than the other, but total numbers may be different. Everybody with me? And the reason we do these proportionalities, these rates, is so we can do comparisons. Okay, so we compare New Jersey and we compare Pennsylvania. All right. So these both are from, there's a website you can go to, it's called AIDSview, right? It's got lots of information you can put in your zip code. I'm gonna show you one in a second. Okay, so this is Philadelphia. This is all the different parts of Philadelphia, right? And so what it's showing you is HIV, AIDS in relation to poverty. Okay, and so one of the things I want you to take away from us, from this lecture, is that there's a strong correlation between poverty and HIV. Okay, all right. If we were to look at this related to medium home income, once again there is a link. How much you make potentially can make your chance of getting exposed. Not saying that if you got lots of dollars and you have sex with somebody who has HIV, you can't get HIV, but it means that the chances, because of those environments I tried to explain to you, plays a role. All right. So when we think about male, so I'm just giving you some between Baltimore and Philadelphia. So if you look at how new diagnoses are happening, so in Baltimore, male transmission, the blue is IV drug use, the red is men who have sex with men or male-to-male contact, and then the other two are heterosexual contact, the purple, and then other, right? So you may not know. For female transmission, you see that the pie chart is very different. And so for females, the vast majority of it's heterosexual contact, about the same percentage, close to the same percentage for IV drug use, and then for other. All right, and the reason I'm trying to tell you this is because depending on who you are and where you live, this plays out a little bit differently, and we need to think about this in that context, right? If we look at Philadelphia, female heterosexual contact makes up almost 70%, and then the rest is IV drug use, right? Whereas male contact, male transmission, this once again, new cases, is a little bit different, right? And so if you think about, just looking at Baltimore and Philadelphia, even though we're talking about HIV, new incidence of HIV, how it's happening is different. And so we have to think about localized evaluation of each of the epidemics or each of the way it's being transmitted. That has not always been the case, okay? And then if you look at North New Jersey, once again, slightly different transmission, right? Okay, and so the reason I bring this up to you is because, once again, I want to reiterate place matters. All right, if we look at how in Baltimore, Philadelphia, Newark, look at how it would look if you looked at individual people, this is how it would look, right? And basically it's telling you for black women in Newark, 18 to 1 times their white counterparts of living with HIV. In Philadelphia, it's 24.4 times. All right, in Baltimore, it's 19.9. There was a comment that was made at Hopkins that said if you are a black woman in parts of Baltimore, you basically have 4 encounters with men and get HIV. If you are a woman no matter what your race was, this is before the oil binge up in North Dakota, you could be in North Dakota and have sex with 15,000 men and never get, not that you would, but never get HIV, all right? Once again, showing you place and exposure and prevalence of it plays a role, all right? Once again, if you're looking at how this plays out related to men, once again, in Baltimore, it's 5.4 times. Philadelphia is 12.8. In Newark, it's 5.9. So just once again to give you the context of how these rates play out a little bit different depending on the environment. All right. So I'm going to close and just give you some opportunity for questions. So one of the things you want to realize is that people living with HIV, because of the retroviral treatment, are able to live longer. So now for many places, HIV is a chronic disease. Now what we're finding out is as those people age, we're finding out if you have HIV and you're aging, how age and how disease and how things affect you, we're learning it, because we have these cohorts of people that have been kind enough to let us study them. We're finding out they have unique kind of comorbidities, right? Things that are happening to them that are different from populations that are not HIV infected. And we're trying to get a better sense of that so we can think about how to treat them. All right, let me get you 1 second, okay? And so I'll I'm gonna close and I'll get you 1 second. So this is Jose Bormeister. He just came to Penn a few years ago out of University of Michigan. He is a phenomenal researcher at Penn. He is coming up with, he's really interested in MSM and gay men and how we can develop mechanisms in order to help them both stay in compliance with their meds, get tested, and also kind of reinforce efficacy of their own self-worth and use of medicine. And he is a great person that's doing very cutting edge. He's working on an app that actually is going to potentially be out in a few years where people can look and see, like, you can't necessarily test your status, but you can see things about your behavior and move forward and also get counseling. The other one, and this didn't show up for you, is Bridget Bronner. Bridget Bronner does a lot with adolescents, but she's looking at how place and neighborhood plays a role, not only HIV, but STIs in different communities in the Philadelphia and Camden area. All right, I want to just thank everybody and just let you say that HIV is made up of people, and it's the people that spread the disease or have the disease, and so we shouldn't think of people as other, we just think of them as people. All right, thank you very much. I'm open to questions.
Which cities have the highest AIDS population?
So the last, okay, so it's how you look at it. So if you're talking about proportionality or you're talking about total numbers. Okay, so total numbers is New York City. Okay, if you talk about proportionality, San Francisco.
But I thought maybe it used to be, like, those used to be the highest AIDS populated cities, but maybe it's changed.
They haven't really changed. And part of that is because many of the communities that are at risk for HIV and AIDS still live in those communities. Although in San Francisco, because of gentrification of the city, some people that can't afford to live there have to move out to East Bay or other parts.
When we think what else? There's also, like, which countries? Like, are there a lot of AIDS in Canada or
So the thing you have to realize is that still the place where it has the most HIV and AIDS is still in Africa, sub-Saharan Africa, yeah. Right? Canada still has some, but the thing about it is that we don't fully know what's going on in some places like China. We know there's HIV there, but they don't really report that information to us. There's also HIV in Russia. We don't necessarily know that. So what I'm trying to say is that we only know where the places where people give us the data and share the data.
Okay, can I ask you one more thing?
Sure you can.
This was in the past, but do you remember when Princess Diana used to visit people that had AIDS?
Yes.
And, like, you know how she did it?
You mean she would go visit them? You're saying?
Like where, like, she would go, like, around the world visiting people with HIV, right?
Yeah, so here's the thing. If somebody has HIV or AIDS, you know, unless they're like, you like have a blood stick with a needle or something, there's nothing about them. They're not radioactive, right? But that was the belief back in the day. I mean, even nurses didn't want to touch HIV/AIDS patients because they thought that they might get it from touch. So there was a lot of miscommunication and misnomers and a lot of, just a lot of fear about it. So people have found out that that's not really a problem.
But Princess Diana was like the opposite. Like she was.
Yeah, it was lots of people. Yeah, I mean, she was one of them. But there were people on the front line all over the world that were doing it.
I'm sorry, guys, to interrupt you. Don't leave before you sign. Please don't forget to sign.
I was going to say, when you were talking about the four H's, the fourth H was heroin.
Yeah, thank you. Yeah, it was IV drug users, right?
But Princess Diana was the first person, the first public figure to touch somebody that was known, known that was infected with HIV without gloves, or like it was skin.
Well, I mean that the media.
Yeah, that's
the media brought out, right? Because there were still people. I mean, I knew people that were in the front line. They were touching people with gloves.
So can I ask one more question?
Yeah, sure.
So I think that, like what you were saying about like Penn and Indiana and the needle drop, I think that that's, people just see that, they're just like, oh my gosh, we're just supplying addicts with needles, and it's like, no, like you have to like act locally, think globally. So like you have to like take care of one thing while you're taking care of another, and I think that that's a huge misconception. But Ken, you just clarified once, because a lot of it's like blood to blood, like, contact. Once blood hits air, what is the rate? Because doesn't after like a certain amount of time, it kills the virus, like once it oxidifies or something?
Yeah, so I mean, the virus doesn't live, two things. First of
Outside
all,
of the body.
we need, for you to get infected with HIV, you need a lot of virus, right? So if you just get one virus from somebody, if they're shedding one virus, the chance of you getting HIV infection is very slim, okay? So if it doesn't go from a person's blood to another person's blood like really quickly, it can die. It's not a hardy virus outside of its host,
Yeah.
okay? So that's what, the other thing about needles is the fact that Hopkins and some other places have developed very effective teaching methods for people who inject drugs that basically they just don't share the needle, right? They teach them how to, but that's why you need needle exchange, right? They teach them how to go through it because for some injectable drugs, it's a very traditional, they have a tradition. So they have a shoot up or partner or partners and they go score their drugs and they go someplace and they have like this whole ritual they go through, right? And if you can bring in key components of individuals in those communities and start to teach it to them and then they can spread it out, right? This is called diffusion of public health ideas, then potentially you can decrease the number of people that get it through that kind of method, okay? All right, but I mean the real issue, I'll get to one second. The real issue we have dealing with one that's going on now that has nothing related to HIV but is connected to HIV is that we have things like Tinder and Grindr, and so we have things where you can connect with some, I know it's a social networking thing, but it also is used to engage in other acts, right? And because you basically just met this person minutes ago, there's no way for you to know status, right? And so if that's how you're doing, that's I'm not saying I'm not judging you, but I'm saying if that's what you're doing, you need to put testing as a standard regimen of your life, okay? You had a question?
Yeah, so I heard news reports about UNAIDS, the UN agency. There is like a plan to make the world HIV free, like in the
90-90-90, yeah.
In a couple of decades.
Yeah.
So absent vaccine, what do you think is that prospect happening?
So one of the things people are saying, because we have these drugs that can minimize people's ability to spread the disease, right? That if we target people early on, so the big push now is as soon as you come in and get tested and you have a risk factor, they will prescribe drugs for you so you can start taking drugs before you even know that you're positive or negative, okay? So that's one way. So because what we're finding out in lots of places, it's that period of time between you first getting infected and when you find out that you are highly contagious and also potentially also spreading to lots of people, right? And so the thought that we can start that process early on, we can minimize, and they've done math to make this work. My problem is that as we see, and I'm not trying to get political, but I just want to show you how chaos happens. As we see, if certain governments change policies and remove like either funding or remove personnel, you have people who may be on medicine that are now in a chaotic environment, and if you're trying to flee for your life or trying to move, you may not necessarily think about having, or you might have enough AIDS medicine or HIV medicine for a month, but then your whole infrastructure is knocked out.
Right.
So I mean, so those individuals who have it, the virus can come back out and they can still potentially spread. So I mean, until we get and people work on different ways to do the vaccines, but the drug regimen is functional, but it has every limitation that having to have an infrastructure has. But I applaud, and I think it's a great idea.
I'm sorry. Allow me to interrupt you because the time, about the due time, we're over. So I will invite you, if you have questions, to come over and talk to Dr. Johnson. I want to present him with a certificate of appreciation from our department, STEM, as well as a hefty check so you can retire.
Thank you very much.
Please come over.
I want to thank you all. You've been a great audience, and I want to thank you for your engagement.